I think head injury is at the topmost, then the spine comes. How we face this problem and try to settle journey, will be presenting that. Dr. Savna,
Thank you, sir. Good afternoon, respected faculty and colleagues. So I would like to start with an interesting spine case, which we encountered in OPD in 2019. He was a 7-year-old male child. He was operated outside AIIMS for a CVJ anomaly through transoral approach and decompression. Patient presented to our OPD with weakness in all 4 limbs for the past 6 months with power of 4/5 in all 4 limbs and with exaggerated reflexes. This is the CT showing the residual craniovertebral junction anomaly with MRI showing a significant residual cord compression. So in OPD, we dated the child for surgery and the tentative date for surgery was in early 2020. But due to first COVID wave, which we encountered in March 2020, we could not admit this child in 2020. Then later on, the child came to us in April 2021, where he still had persistence of symptoms and follow-up scans still showed residual cord compression. In April, just before the second wave of COVID hit India, the child was admitted in our ward, but could not be operated due to second wave of COVID and shortage of OT slots, and we had to discharge the child because child was stable. Later in June 2021, just 2 months after the discharge, child presented in casualty with neurological worsening and respiratory discomfort. We had to intubate the child in casualty, and this is the MR of June 2021, which shows increased cord signal changes on T2 in both medulla and the upper cervical spine. Maybe this is the reason why the child had respiratory discomfort, and we had to intubate the child, and we had to operate the child on an emergency basis. And we did a foramen magnum decompression with extraarticular distraction and occipito-cervical fusion. These are the post-op scans, CT and X-ray, showing significant reduction and decompression. But however, the child is still ventilatory dependent. The child is tracheostomized. The child is in our ward, still on ventilator. So had this been prevented, could this have prevented if the COVID had not restricted us from admitting this child on the tentative date for surgery. So this is just a prototype of many such cases which we encountered, which suffered due to this COVID pandemic. As we all know, around 21 crore people have been affected worldwide by COVID-19, and we have lost around 45 lakh people worldwide. And coming to COVID first wave timeline in India, the first case of COVID was reported in India on Jan 30th, and by September 12th, 2020, India reported its highest daily record cases of about 97,570 people. Coming to second wave hit India on April 1st of 2021, and in a very short period of time, by 9th of April, India surpassed over 1 million active cases. And by the end of April, there was gross shortage of oxygen cylinders began in India. So the challenge posed to us was, how do we strategize in managing the spine surgeries during COVID-19 pandemic? We had to concentrate on maximizing patient safety, maximizing the healthcare workers' safety, and also utilize the limited resources efficiently. So before the COVID pandemic, before 24th of March, our department was functioning in 2 units with 12 attending consultants and 20 residents each, and 6 residents were posted in trauma rotation. But during the lockdown, we had to restructure and reorganize our teams into 3 teams of team A, B, C, out of which each teams had 8 attending consultants and 13 residents who worked on weekly rotation basis. And we had to send 25% of the total residents during the first wave for COVID workforce as well. And during the unlockdown phase, after the first wave, we again resorted back to Unit 1 and Unit 2, which again we subdivided into subunit A and B. Coming to OPDs, as we all know, during lockdown, we had to shut down the OPDs, physical OPDs completely, and we followed up patients only on teleconsultations. But once the lockdown restrictions were eased, physical OPDs were restructured with glass barriers. Level 1 PPEs were used by all residents and faculties in OPD. A single patient with a single attendant were allowed in the examination room. There were designated donning and doffing areas in the OPD, and new masks were issued at the end of OPD. After admitting the patient, any patient undergoing surgery under the Department of Neurosurgery, we have taken a COVID-related consent. So after we explained the relatives and the patient regarding the risk of contacting COVID-19 infection during their hospital stay, and also explain them regarding the increased chances of post-operative complications due to COVID, which has already been proved in literature. This consent thing is still followed in our country. Now I would like to invite Dr. Abhishek to explain the statistics and data.
Thank you, Pauna. I'm Dr. Abhishek from Neurosurgery. I'll be presenting the data and statistics of the patients who underwent spine surgery at our institute under the Department of Neurosurgery during the COVID pandemic. We operated 238 patients in a span of 18 months during the COVID pandemic, starting from the 1st March 2020 to 30th August 2021. When we compare it with the pre-COVID era, we can see that from September 2018 to Feb 2020, we have operated 1400 patients. That means there was a 6-fold reduction in the number of spine cases we have operated. One of the fact why this happened was we also prioritized operating patients with head injury, intracranial bleeds, intracranial tumors with neurological deterioration over spine patients because they pose threat to life. Now, when we compare the etiology of patients who were operated in the pre and post-COVID era, we can see that there is no significant difference because in the post-COVID era, we selectively operated patients from each category of spine diseases who were sicker. But when we look at the location of pathologies which were operated, we can see that there is a drastic reduction in the number of spinal cases, spinal lumbar and sacral cases which were operated because we prioritized operating cervical and thoracic cases because they lead to myelopathy with consequent permanent neurological deficits. As we all know, there was a nationwide lockdown during the COVID-19 pandemic, so we could only cater to patients who could come from the adjoining 3 to 4 states. We can see that when we see the demographic data, we have operated patients from almost all the age groups, and 66.8% of these patients were male. Out of all the patients operated, 45.8% patients required instrumentation because most of these patients were having spinal injury with instability. Now, going to the post-op complications, 0.9% of our patients developed wound infection in the post-op period, while 7.1% of them developed post-op pneumonia and sepsis. 19.9% of these patients required post-op prolonged ventilation. Most of these patients were patients of cervical spine injury who required ventilation even in the pre-op period. Out of 238 patients whom we had operated in the COVID, only 5 patients died and all of them were cervical spine injury cases. Now I would like to invite Dr. Devashish who would present how we manage spine surgeries at our institute during the COVID pandemic.
I'm Dr. Devashish. I will present regarding how we managed spine surgeries despite this COVID pandemic. We triaged the patients, all the spine patients, based on necessity of intervention. It prevented unnecessary exposure of both the patients as well as healthcare workers to the COVID-19 infection, and it also provided efficient utilization of healthcare resources. So we broadly divided all the spine cases into three categories: emergent, urgent, and elective. This was based upon the risk of developing a permanent neurological deficit. The emergent cases included any progressive or severe neurological deficit due to any compression from any cause, any spinal instability which is at high risk of developing deficit, any epidural abscess requiring surgical decompression, or any post-operative wound infection. These cases should not be delayed and should be operated immediately. Under the urgent category, any myelopathy due to spinal stenosis, any spinal infection which is not responding to medical management, or any persistent significant neurological deficit with or without any deformity came under the urgent conditions. These conditions included like any painful conditions like lumbar disc herniation or any painful fracture leading to progressive deformity. These cases we should proceed if the adequate healthcare resources are present and local guidelines allow for their surgery. Under the elective cases, all the spinal conditions uh, which are chronic and like degenerative disc disease, any spinal stenosis, or any scoliosis or kyphotic correction, or any symptomatic hardware, these are not significantly endanger the risk of developing any deficit immediately. So these cases should be, we should consider postponing during the peak of the pandemic. So under the emergent cases, there was a case of CA breast presented to us with pathological fracture leading to cervicomedullary compression. We operated this case in emergency by transoral odontoidectomy with occipitocervical rod fixation. There was a case of a traumatic C6-7 anterolisthesis, Asia grade A, with significant canal compromise and cord compression. We operated with the C6-7 ACDF, anterior cervical discectomy, with right-sided C6-7 and left-sided C5 to 7 screw and rod fixation. And there was this case of L4-5 PIVD who presented to us with acute cauda equina syndrome. We had to take this patient in emergency and provide immediate decompression to prevent permanent bladder dysfunction. We did a L4-5 microdiscectomy and bladder symptoms improved after the surgery. Under the urgent conditions, we encountered cervical intramedullary tumor like which was ependymoma. We did a C4 to 6 laminoplasty and excision of the tumor. There was this case of multiple myeloma who underwent presented to us with conus medullaris syndrome and was taken urgently, and L1 corpectomy was done with foraminectomy with pedicle screw fixation, and expandable cage was also played. The patient improved neurologically in motor power after the surgery. There was this case of traumatic odontoid fracture. Although the patient had only neck pain and was neurologically intact, we did an MRI which showed ruptured transverse atlantal ligament, and there was high risk of causing cervicomedullary compression due to the unstable injury. So we operated this case with C1 lateral mass and C2 pass-through rod fixation. There was a case of traumatic L2 burst fracture, which was Asia grade C and Telix grade 6, presented with incomplete spine injury. We operated this patient immediately with L2 laminectomy and removal of retropulse bony fragment, and bilateral screw and rod fixation was done. Coming to the elective cases, some cases which presented did not have any risk of immediate neurological deficit like this lumbar PIVD. So we postponed this case and redated him so that to a later date. There was this case of spinal dural AVF. We operated this case when all the restrictions were eased out, and D10 laminectomy and ligation of the fistula was done. We developed novel solutions to limit intraop contamination, like use of suction devices which contains sodium hypochlorite solution to prevent COVID-19 transmission in the operating room. And also we use the special plastic drapes which covered the microscopes and limit aerosolized dust particles. We faced a lot of issues in the COVID pandemic. There was a lot of difficulty in procuring implants at the peak of pandemic because of logistic and transport issues. A lot of patients came COVID positive just before the surgery, so they had to be shifted to trauma center for isolation and COVID management. And a lot of resident doctors as well as faculty came positive for COVID-19 during the peak of pandemic. From our department, maximum 18 to 20 people came positive in the late week of April. Due to the significant reduction in number of cases, which was a six-fold reduction, so the training of residents for spine surgeries was also reduced. We had overcome this hurdle by having spine masterclasses and online training classes. We also organized a hybrid conference. Now I would like to invite Dr. Sachin to give concluding remarks. Good afternoon.
The last 1 year has been really disappointing, we all know. It was more disappointing for non-COVID pathology patients, especially spine surgery patients. Even with the peak of our abilities and when everything was normal, we had a waiting list with 9 OTs, including trauma center. We had a waiting list of 1 to 2 years. But during the pandemic, at one point of time, we had only 1 OT that was emergency. Many issues, but we know that it was an extraordinary situation and we collectively had to face it, and we did that successfully. We tried to help our patients to the best of our resources and abilities and prioritize them. But however, we know that it's inadequate. With gradual opening, now we are slowly limping back to normalcy, though pending the complete reopening of trauma center, it is still inadequate, but still we are trying to help as many patients as we can. I'll like to request our head, Dr. Kale, to give some comments.
Good afternoon, everybody. One striking thing which I noticed, and I was talking to Dr. Ramam just a few minutes ago, that in general, the medical specialties, if I can say so, and in particular the surgical specialties, the complete uselessness has been demonstrated by this pandemic. It's unfortunate, but it's true. For 1.5 years, neurosurgery was running with one theater. Nothing happened. The world just went on merrily. So was cardiology. So was cardiac surgery. Nothing happened. So it really makes me wonder, what the hell are we doing? What are we doing when things were normal? Anyhow, we are getting back to normal. We faced all these challenges. And somehow even the patients didn't complain in the last 1.5 years. Nobody made any serious complaint. So they're very understanding, or some of our cranial patients, they just die. So they're all dead. Exactly. They're dead. Our patients are dead. So, but still, it makes me wonder, what are the priorities? What are our priorities? How do we look at our priorities? And in future, this pandemic, how does it change our thinking? How do we prioritize later on? Suppose there is a third wave or a fourth wave. How are we going to prioritize? Are we going to close down the trauma center and sit again? Or what are we going to do? We must seriously think about all these things. Thank you. Thank you for your attention.
I think it's a larger question, and the seminar is more suited for a debate or a CCR 1 year, 1 hour session. Neurosurgery, even without COVID, is quite like COVID. So I think the gap is, although it cannot be overemphasized, but I think it's a generic issue. It happened in all the more so in surgical disciplines, medicine discipline. But what point you raise is worth introspection. That at some places the mortality didn't change much. Uh, it has been a disaster for all of us. So I think we really can't calculate the immense loss that people have. It is so much that people don't even talk about it. But I think the larger question is, was our response right? Is converting a specialist hospitals into COVID hospital, is that the right thing to do? I don't know the answer. But I really suspect sometimes that probably we didn't do the best. And this is a question which needs serious,
all come in we see 5-6 patients of CA gallbladder who could have been operated 5 months back, 6 months back, but they're all inoperable. CA breast, we are seeing advanced pregnancy because we were hardly operating during the you have done a lot of work. We were hardly operating because it's a mixed operation theater, and we could hardly get operation theater maybe once a week or sometimes that too for one case or 2 cases. It's a bad situation. I have now, I think, more than 100 patients on made a ileostomy or a jejunostomy because of the bad perforation peritonitis they came with, and I don't know how to close them. More than 100 patients during this pandemic, where we could have done a primary anastomosis, but they have all landed up with a jejunostomy, ileostomy. Some patients have a double jejunostomy, double ileostomy. So I don't know where to adjust them and how to close them. So it's a real bad situation for the surgical specialty. And if you talk about resident training, none of my third year residents know how to handle a laparoscope at the present moment. Even the third year PG students or in the third year MCS students. It's a bad situation for training. So I don't know whether we were right or we were wrong. I'm nobody to comment on that, but it's a bad situation. Then I would not have made this comment.
I really think director and administration was here, but I have another point to make. We as faculty, are we up to the job that shall we not now have a 24-hour AIIMS running? Shall we not show to the country that we care, that AIIMS is now running 24 hours for next 1 year, whatever it takes, and let's clear the backlog of at least some time. Can we do that? I mean, I was telling cardiology that let the cath lab run 24 hours a day. It will be other challenges, but I think we should show to the society that we care.